Okay, so today's is going to be tracheostomy. I don't know how much you know or you've heard about tracheostomy, if any of you have seen it. I know some of you in your Viva, you got a question about it, but we tried to be as fair as possible and not to make it very difficult for you, considering we had not done the lecture yet. So basically today, what we are going to go through, we'll do the definition, types of tracheostomy, the relevant anatomy that you should be aware of, the indications and contraindications to a tracheostomy, and then the complications. And at the end, if you have any questions, then they can be addressed. So there are two things when we talk about tracheostomy. There's what we call a tracheotomy, and then we have to differentiate that from a tracheostomy. So tracheotomy basically means having a surgical or making a surgical opening into the trachea. So it doesn't matter why you're doing it. That means you make an opening and then you close it immediately. So that is tracheotomy. When you open into the trachea surgically, that is tracheotomy. A tracheostomy, it goes beyond a tracheotomy in that when you finish opening into the trachea, then you create a stoma. That means the connection of the trachea to the skin. So it becomes a tracheostomy. So there are different types of tracheostomy tubes. And before maybe we can go to the different types, we should look at the different parts for the tube used for the tracheostomy tube. And I hope this is clear to you. So you find that the tracheostomy tube can be cuffed. When you say cuffed, it has a cuff or uncuffed, depending on what the indication, why the person has the tracheostomy tube in or how long they've had it in. So it could have a cuff or it could be uncuffed, as the one that we have in the image here is cuffed. So it has a cuff or a balloon. And this has a one-way valve, which is used to either inflate or deflate the cuff. So you've seen this same mechanism when it comes to urinary catheters. So this is not new. So a cuff and then this balloon that you can, that has a one-way valve that helps you in inflating or deflating the cuff. So you also have what we call the tracheostomy strings. These basically help you to secure the tube itself when it has been placed inside into the trachea. These ones are, you sort of fix them to the skin and it helps you to prevent it from coming out. For example, when someone coughs or when they're moving, turning, so that the strings help you to secure it. This is what we call a flange. The flange helps to prevent the tube from going into the trachea completely. So it's beyond this, you only have this length into the trachea, and this is to the skin. It's external, so it prevents it from entering completely. So you have an outer cannula and these two tubes down below here. This is, they go inside here, okay? So this is your outer cannula, and then this is an inside cannula, and then an obturator. So these, when you're placing the tracheostomy into the trachea, they are all assembled together. And then after placing it, you remove them so that you open the airway. And for the, you remove the obturator so that the airway is patterned. but you leave the inner cannula inside. And this one is what the patient keeps removing to clean and then put back. For example, if it has got mucus plug or any blood or any form of debris, you remove this, and this one remains inside. But not all tubes have this one. Many tubes come with just the obturator and then this outer cannula. So that means when someone is cleaning it, they literally have to take this out and be able to clean. So this is what it should look like when it's inside. Here is your stoma, and then the tube. We talked about the flange, preventing the rest of the tracheostomy tube from entering inside. And this is what you use to inflate and deflate the cuff here. So the tracheostomy should be that the tracheostomy, the rest of the tracheostomy tube should be inside the trachea. Okay. So we'll move to the types of tracheostomy tubes. We have what we call the metallic, and these ones are based on what is used to make them. So you have metallic tubes and then the synthetic tubes. So the synthetic tubes are made from plastic, and the synthetic tubes can be cuffed, uncuffed, fenestrated, double lumen, adjustable phalanges. Flange tube, sorry. When we look at this, I mean, the metallic tubes are these, just like the name says, they're metallic. So you see even the obturator that you put inside here is also metallic. This is an example of a synthetic plastic tube, which has no cuff, okay? And this one doesn't have it's not fenestrated. This is a fenestrated tube. What we mean by fenestration is this hole here, okay? This one doesn't have it. This one has the hole. What's the importance of this hole? When you put in a tracheostomy tube inside someone's trachea, that means air enters into the trachea, then to the bronchi, then down to the lower airways through this tube. That means even coming out, it does the same. So it doesn't go up to the larynx for someone to be able to phonate. So for this tube, someone cannot talk or that they don't have a voice. This one here, the only way they can, for this first tube that has no fenestration, the only way they can be able to make sound is let's say, let me use this tube. They apply their thumb here so that they sort of close it off, and the air is supposed to go around the tube and then goes up the trachea. And that's how they can be able to, up to the larynx. And that's how they can be able to phonate. So for this tube, you can actually have some air escape through this fenestration, and it goes to the larynx through the vocal cords, so they can have a voice. They can be able to phonate. Same applies to this one. This one has no cuff, so you have a cuffed fenestrated tube and then an uncuffed tube. We talked about the double lumen. It's just about these different tubes being able to have an inner cannula and external cannula. For this one, you see it has an obturator. It has only one, so there's nothing else you take out. So for the tracheostomy tubes, or for tracheostomy, it can be a temporary tracheostomy or it can be a permanent one. For permanent tracheostomy, that means this is a lifelong, it's a lifelong stoma that someone has to have. And usually for those ones are patients who have had, for example, laryngeal cancer, and they have a total laryngectomy. That means the whole of their larynx is taken out. So they sort of form a stoma to the outside. They breathe through that stoma, and it's going to be for the rest of their life. So that's a temporary one. That's a permanent one, sorry. For the temporary one, depending on the indication, those are the ones that you have hope maybe in the future that when you sorted out whatever issue the patient has or the indication for the tracheostomy, they can actually use their larynx later on. So that would be a temporary tracheostomy. And still for the temporary tracheostomy, it's further subdivided into elective or an emergency tracheostomy. And this one is just based on the circumstances under which it was done. For an elective tracheostomy, that means one has, you know what elective means. It's a planned procedure. The patient is not at risk at the moment, so it gives you time to schedule the time when and where you're going to do the procedure from. For an emergency one, it's because of an emergency indication. Someone needs an urgent airway. So you have limited time. You have to save a life here. So that's basically the main difference between the two. Elective, the patient is stable. They are not at any risk at the moment, and you are allowed to schedule a time when the doctor and the patient the optimum time for both of them, and then that's when the procedure is done. So when we talk about anatomy, what do we need to know, or where is the tracheostomy done? So we are talking about neck anatomy. And from this image, I think we should all be aware of the laryngeal prominence, which is more marked in men. For women, it may not be so clear, but still you can be able to tell with palpation where the laryngeal prominence is, or the Adam's apple. So our tracheostomy is going to be placed midway between the laryngeal prominence and the sternum. Yeah, this should be your notch here. So midway between the two, this is where your incision is going to be. And we estimate that at that point, you're away from the cricoid, you're away from the cricoid cartilage, and you're going directly onto the probably second and third tracheal rings. So on the surface, what you need to consider is the laryngeal prominence, and then the notch for the sternum here, and midway, that is where your incision site is going to be. You'll find that this length is different, considering if it's a male or female, if it's a child or an adult, it's usually different. So that's why we may not exactly, based on maybe centimeters, and we are considering midway the length. So usually the incision you're making here can be a horizontal one or a vertical one. And that is dependent on whether you're dealing with an adult or a child, because we know that children, then their neck is short. So if you're going to make a horizontal one, it's usually more complicated and more difficult. You find that the neck is short and small as well. For you to make a good incision that is going to allow you to dissect and reach the trachea, it may be more difficult, and there are higher chances of you injuring other important structures in the neck. For example, the big vessels, we have the carotid and the jugular, the nerves. So because we want it to be in the midline, the tracheostomy is supposed to be done in the midline. So for children, it's preferable that you do a vertical incision instead of a horizontal one. And then also for the adults, it's also dependent. If it's an emergency, you may not have to do the horizontal one, because the horizontal takes a lot more time. Yes, it's cosmetically better, but it takes more time, and the chances of injuring muscle and vessels is higher for horizontal. So if it's an emergency situation, chances are that you're going to do a vertical incision rather than horizontal. And we're going to look at the different layers that you go through. Here we see that you're going to go through skin, subcutaneous tissue, then you have the platysma muscle. Sorry. From platysma, you'll have the investing fascia, and then you have the muscles, for example, the sternothyroid, the sternothyroid muscle here, sorry, should be here. So you have the deeper muscles of the neck. These are usually vertical. You realize that in the midline, you don't have much muscles. They're paramedian. So if you keep to the midline, even the bleeding is minimal. That is why for emergency situations, you find that a vertical incision is a lot quicker because you're not going through a lot of tissues. You're going through skin, subcutaneous tissue, and then the different layers of fascia. Maybe what you'll find deeper should be the thyroid. And we prefer to retract it superiorly, so that you go directly to the trachea here, the trachea, and then you can make an incision to the trachea and you're into the airway. But for the case where the thyroid tissue is big, then you have to divide the isthmus here so that you get to the trachea and insert the tracheostomy. So it's one of those procedures that require experience. You would not want to try it as a first-time thing unless you have supervision. So it's preferable that you're confident before you try it. Otherwise, most cases, if it's an emergency situation, you will not do what you're supposed to do. So why would anyone need, what would be your indications for doing a tracheostomy? One of those is upper airway obstruction. So for the upper airway obstruction, we need to know where does the upper airway begin and end, and where does the lower airway start from. So whatever causes obstruction to the larynx, to the hypopharynx, to the oropharynx, to the nasopharynx, that is upper way. That is upper airway. So for those different things that cause obstruction, one of the way of creating an surgical airway is tracheostomy. But if the obstruction is actually below the larynx, that means your tracheostomy will not work. So you will need to know where the obstruction is. If it's the larynx and up, yes, the tracheostomy will work for you. If it's actually below the larynx, it may not exactly work for you, okay? So not everyone who has airway obstruction will benefit from a tracheostomy. And there are different causes of upper airway obstruction. For example, in form of congenital masses that could be obstructing the airway. For example, you could have a cystic hygroma. It could be a tumor of some form that is compressing on the airway. Traumatic causes, for example, you have head injury, where you have facial fractures, mandibular fractures. If you have neck trauma and it's causing air obstruction, so for those, you need a tracheostomy to relieve the upper air, the obstruction. Then you have things like infections, for example, laryngeal infection. If you have a laryngitis with edema and it has caused obstruction, you may need a tracheostomy. The other case is tumors. We have laryngeal cancer, you have cancer of the hypopharynx. So depending on how big the tumor, when it causes obstruction, you need an alternative airway, which is a surgical airway, and you need to do a tracheostomy. Then for cases of people with vocal cord paralysis, this can be a result of tumor compressing on the recurrent laryngeal nerve. So you find that you lose innervation to the vocal cords and they do not open. Such patients will also need a tracheostomy to enable them to breathe. The other indication for tracheostomy is protection of the tracheobronchial tree, and these are it's indicated in patients who cannot be able to control their airway. Either they have neurological disease. For the example that I can give, for example, those days when people would have polio. So depending on the level of the poliomyelitis that they're getting, Guillain-Barré syndrome, if the cervical and the nerves are also affected. Then we talked about trauma. For trauma, these are patients that have had head injuries, severe, moderate to severe. They're probably comatose and they cannot control their airway. For those ones, we still do a tracheostomy to sort of help them, to prevent them from aspirating. The other cases are individuals where we anticipate, excuse me, individuals where we anticipate prolonged ventilation, for example, for patients in ICU. If you suspect that they'll be there longer than a week, it's recommended that they do a tracheostomy. Why? Because the time they're in ICU, they are intubated. And one of the causes of stenosis, subglottic stenosis, is prolonged intubation. So to prevent this, it's usually advised that you put a tracheostomy for these patients. And then you can also have patients who are going to have several head and neck procedures that are going to compromise the airway. For example, if you're having mandibular surgery or any head and neck surgery where they cannot put a tube, or where the anesthetic tube is, where that tube, the endotracheal tube is going to be to disturb the surgeon, they cannot work around it, then it would be recommended that a tracheostomy is put so that the surgery can go on. So what we've seen the indications, what could be the contraindications to tracheostomy? There's really no absolute contraindication because it's based on the how the surgeon judges it. One of those can be that you anticipate that probably the obstruction is lower down, and if you do a tracheostomy, you're actually going to go through tumor. So for such cases, it's better you carry out definitive management. For example, if someone has extensive laryngeal cancer that is going below the larynx itself, and if you do a tracheostomy, you're going to cut through tumor. For such a patient, it's better that you plan for definitive management, which could be total laryngectomy, so that you prevent seeding of tumor. In other words, carrying tumor from where it is to other areas, so that when you're done with your procedure, that there are higher chances of the patient getting better without getting recurrences. And then the other thing is end of life issues. Basically, what's your prognosis? Why are you doing a tracheostomy? If someone has advanced stage tumor, if you explain what you're going, that yes, you're trying to give them an airway, but this is not going to cure their disease, or it is for palliation. Some people can tell you, no, it's okay, I don't need it. So it's dependent on the patient's decision and all the caretakers as well when it comes to end of life. If the procedure you're doing is just going to probably prolong their life by just mere days, they may not want it. The other case is where we have bleeding disorders. For example, you have platelet abnormalities, you have other inherited bleeding disorders. You need to be aware and prepare yourself. If you're not well prepared, then you'd rather not do the procedure, because we know the neck has a lot of blood vessels. And for someone who has already bleeding disorders, this can be your worst nightmare. Instead of saving life, you may just make it shorter. You may do the tracheostomy and the person bleeds to death. So whatever the disorder may be, it should be taken care of before you embark on doing a tracheostomy. The other contraindication is if you're having active cellulitis of the anterior neck. So to prevent spreading of this infection and maybe even seeding it into the trachea, if it's an elective tracheostomy, it would be better that you hold on and treat the infection. When the infection is better, then you can plan to do a tracheostomy. So what complications can you get from this? These can be immediate, intermediate, or late complications. The immediate, one of those is anesthetic complications, and this has to do with the either what drugs are given during anesthesia, and where you can have anaphylactic reaction to the drugs, and the different maneuvers that can be done. You could have hemorrhage, for example, if you injure any of the vessels in the neck, you can have excessive bleeding. When you open the airway, there are chances of getting an air embolism into the vessels. Apnea, this usually happens for patients that have been chronically obstructed. For example, someone has laryngeal cancer and they've not been able to breathe well for quite a long period of time. So when you actually when you put a tracheostomy and open the airway, it's like you're flooding them with a lot of air, which the body's not been accustomed to. And you sort of shut off their carbon dioxide drive, and this patient can become apneic. They can stop breathing. So you need to be able to know and be able to manage if this happens. You could have a cardiac arrest. Depending on where you placed your tracheostomy, you may damage the vocal cord structures. The intermediate complications, you have things like tube displacement. You may have surgical emphysema, pneumomediastinum infection, tube obstruction, whereby the obstruction can be maybe from a blood clot, it can be because of a mucus plug. You could have tracheonecrosis. This usually happens for cases where the tube is left cuffed for some time. So it exerts pressure at a certain point in the trachea, and you can end up with pressure necrosis in that area. You could have tracheoesophageal fistula. If you make the incision too deep, we know that the posterior aspect of the trachea is related to the esophagus. So you may go through the trachealis muscle and you end up in the esophagus. So you have a tracheoesophageal fistula. Then dysphagia. That means a patient fails to swallow. With the size of the cuff or the size of the tube, it can compress on the esophagus posteriorly and causes dysphagia in a patient. So for long-term complications, you could have things like stenosis, and this is because of healing with scar formation. So you end up with a smaller lumen of the trachea, and they'll still present with difficulty in breathing. You could have accidental decannulation. For example, if you've not secured your tracheostomy tube well, or if the patient or the caretakers don't secure it, and then maybe the patient is moving or they cough and then it comes out. So if there is now no one to help the patient, these people can end up dying, because without the tracheostomy, the stoma is not parted. Depending on how long ago the tracheostomy was made. Then you could have a tracheocutaneous fistula. This happens when, for example, the patient does not need the tracheostomy anymore, so it's removed. That stoma is supposed to close within a week. It should be closed, but for some people it persists. So you have leaking of air from the trachea to the outside through the stoma. And then also a disfiguring scar. For example, you removed the tracheostomy, the patient doesn't need it anymore, but that place may heal with scar formation. That in some people that have that form hypertrophied scars, it does not look good. So they end up with a disfiguring scar. So how do you manage a patient after a tracheostomy? So in attendance or someone that's able to and so also how to care for the tracheostomy itself. Um, these patients should be given, should have, not given, they should have a writing pad, because we've said that there are different types of tubes. There are those that are fenestrated and those that are not fenestrated. For those that are not fenestrated, the patient will not have a voice. They cannot be able to speak. So they need a way of communicating. So they should have a writing pad if they have to say something to the caretaker or to maybe the medical personnel, they can be able to write it down. This can be a problem for cases where the patient is illiterate, so it becomes difficult in how they can be able to communicate. And the other thing is they should have a bell. This is not okay for most of our patients don't have this, but this is what should be there. Why? Because like I said, they do not have a voice. They cannot be able to speak. They cannot make an alarm. So a bell is necessary, that when they ring it, you know that they have an issue to address or they need help. So it lets the medical personnel know. For some institutions, for example, the bed where the patient is placed could have a place for a bell, so it makes an alarm, maybe a switch that a patient can flip, and somehow the medical personnel is alerted. And then they should have alternative tracheostomy tube, and which is of a similar size, available with the patient. So for the case where the tube is obstructed, they can be easily changed to a similar size so that someone is able to breathe. Then you should also have available suction, so that, because that is the only way you're going to get the tracheostomy tube cleaned as it is in the patient. You suction around it, suction inside the tube to take out any mucus plugs that can be obstructing to the patient. So the basic care you should really, when you're having a patient with a tracheostomy, you should always be able to tell if they are hypoxic, if they're not able to breathe. And how do you check this? For example, normally when we are all breathing, it should be silent. it's not evident. I mean, it shouldn't be making noise. So the moment someone is breathing through a tracheostomy and you can hear them, then that means it's obstructed, either with excessive secretions or there's a plug of some form and it needs to be cleaned. So you have to be on the lookout. Are they having pain? Is there an infection? Is there a discharge around the tube or coming from the tube itself? So it tells you, and this it sort of directs you that you need to either clean or you need additional treatment for the patient to get better. So you should always examine and ensure that the tube is patent. And then ensure appropriate emergency supplies at the bedside. We talked about a tube, an alternative tracheostomy tube, which is of a similar size to what is already in the patient. So that in case of any obstruction, you're able to change easily. Yeah, that is basically it. So if you have any questions, then we can address them.
Thank you so much, Dr. Ruth. It has been a wonderful lecture. There's one question which was in this chat, and I think meanwhile, Chiria, you raised your hand very fast. Maybe unmute and ask as I get the other question in the chat.
Thank you so much, Doctor, for the lecture. My question doing a tracheostomy, maybe you'll give me some about it. Thank you so much, Doctor.
I beg your pardon?
My question is about the appropriate anesthesia while doing a tracheostomy. I request for more details about that. Thank you, Doctor.
Okay. All right. So when you talk about anesthesia, it can be local anesthesia, or general anesthesia. So depending on where you're doing the tracheostomy from, whether it's emergency or an elective tracheostomy. So for the local anesthesia, this just includes what you infiltrate around, sorry, maybe if I go back to this picture, what you infiltrate around where you're going to make the stoma. For local anesthesia, we usually use lignocaine. We combine lignocaine and adrenaline. Adrenaline is basically to cause vasoconstriction so that there's not much bleeding in your surgical field. The lignocaine is what is going to give you anesthesia. So for most patients where it's an emergency situation and they cannot be, let's say the patient is critical and they cannot receive general anesthesia, the local anesthesia is ideal. You infiltrate the area here in the midline, you infiltrate subcutaneously with your drug before you make the incision. General anesthesia, it's really dependent on where you're doing the surgery from. Is it in theater? Is it outside theater? Is it in ICU, or is it on a general ward? Let's say like an emergency ward. So you can have intravenous anesthesia. You could have gases if you're in theater. So those ones really depend on where you're doing the procedure from. And you should have the help of the anesthesia so that someone helps you to monitor the vital signs as you're trying to create the surgical airway. I hope that answers you. But for local anesthesia, lignocaine can work. Lignocaine works.
Okay, thank you, Dr. Ross. Yeah. The person who asked the question went off network. There are some 3 more questions in group in the chat. One from Isaac Miyanja says, can an elective be a subset of permanent tracheostomy?
Can an elective tracheostomy be a subset of permanent?
Tracheostomy.
Because when we say permanent, that means the patient is going to stay with it for the rest of their life. So usually still, that is a scheduled surgery. For example, you're going to, you're going to do a total laryngectomy, then you sort of connect the trachea to the outside. So yes, a permanent tracheostomy is going to be an elective procedure. It's not an emergency one.
Okay, thank you, doctor. Yeah, it answers the question. Another one from Chintu says, how do we prevent pneumothorax when doing a tracheostomy?
How do we prevent pneumothorax?
Yes.
Many times, all these complications, for example, pneumomediastinum, pneumothorax, but I mean, the tracheostomy should not give you a pneumothorax. We talked about pneumomediastinum. But maybe the person, what they wanted to say is surgical emphysema. These ones usually come about with how difficult it is to do a tracheostomy. And this happens maybe in the case where you cannot give general anesthesia, so the patient is awake. So you're basing on their cooperation to do the surgery. You find that if it's an emergency situation, the patient cannot breathe, they're out of air, they are going to struggle a lot. As they're struggling, you're going to open up a lot more than you would have if they were cooperative, if they were not struggling. So most of the times, the only way you can prevent that is to make the patient comfortable. How do you make the patient comfortable? Maybe you give general anesthesia and they are sedated, but this may not be available to you all the time. You may not be able to use general anesthesia. You may not be able to sedate the patient because they are severely obstructed. So sometimes it's difficult to prevent those. You just need to know how to manage them.
Okay, thank you, doctor. There's another one. Can a tracheostomy be done for a patient who's choking, say on a piece of meat? And should it be a sterile procedure considering it is an emergency?
So for someone who is choking on a piece of meat, before you even think about a tracheostomy, you think of the first aid. I mean, what is the first aid for someone who's choking? You are doing Heimlich maneuvers for that person, trying to make sure that you're dislodging this. And remember, we said that the tracheostomy will only work for upper airway obstruction. That means the obstruction should be at the level of the larynx. If someone is choking and this thing has already gone down their trachea, even if you do a tracheostomy, it's not going to you're not opening their airway. Their airway is still closed. Their airway is still closed. You cannot help them with the tracheostomy. Okay, so it's not always. You should know why you're doing it. For someone choking, is it upper airway? Is it lower airway? It may be better to do the maneuvers first, supplement them with oxygen, and then plan to take them to theater before you're surgically opening to put a tracheostomy.
Okay, thank you, doctor. More questions are still coming in. Yeah, I don't know, maybe people understood and now. Yes, so someone has put another question before Mugeni. I tell you to unmute, which was related to the question I was going to ask. I was asking if when do we consider tracheostomy over a cricothyroidotomy? Also wanted to ask about a cricothyroidotomy. When do we do it, or why didn't we talk about it here?
Okay, maybe for the cricothyroidotomy, I mean, you're going to create an opening into the cricothyroid membrane. Okay, so we know where the thyroid is. In this picture, it should be where we know the thyroid notch, right? And we can actually palpate for the cricoid itself. We feel the thyroid cartilage and then the cricoid. So there's a membrane between the thyroid and the cricoid. So you're making an opening here. You're either putting an incision to create an emergency airway. So this is it's something that you do en route to getting an airway, or to getting a more, because it's very unstable. Okay, so you're doing it as you're planning to do tracheostomy. For someone who's obstructed, severely obstructed, for you're going to do the cricothyroidotomy as you're preparing to do that tracheostomy. So it's not something that you do and you leave the patient like that. You do the cricothyroidotomy and then prepare or plan for a tracheostomy, because this one is easier. The tracheostomy is easier to secure. So your incision for the cricothyroidotomy, it should be in between these two lines, where your thyroid cartilage is and where your cricoid. So there's a membrane which you puncture to get into their airway.
Thank you, Dr. Ruth. I'll ask Mugenyi to unmute, but there are still more questions in the group, Doctor, if you don't mind.
It's okay.
Yeah, thank you, Doctor.
Mugenyi Alan, unmute.
Yeah, thank you, Doctor, for the lecture. I was inquiring about accidental decannulation. Does it have specifically to be a long-term complication? Can it occur at any stage after
It can happen at any stage, but it's also something that, because initially the patient may be under the care of a health worker. As you train them, as you train the caretakers, they may not necessarily be, some can be discharged and go back home. So it's something that is continuous. It can happen in hospital, it can happen at home. So it can be an immediate complication. It can be a complication that can even happen after a month. So it's not only a long-term complication.
Okay, thank you, Doctor. The questions in the chat. The one for Alex says, I need more light on how incisions are made. I think he will have to unmute and ask his question properly. Let us first answer these last two questions, then Alex, you make your question more clear to the doctor. Same kind of saying on the slides of tracheostomy, the cuffed fenestrated, are there types from we says question, doctor, in the presence of a hit option, is not anything that ENT specialty.
Sorry, I've not got that question. Could you repeat? I've not got the question. Could you please repeat the question?
Okay, one from Senkai was like on the slides of tracheostomy, the tick. Then Dr. Bwire says, in the presence of a huge goiter, compressing on the larynx and surgery is not an option. Is there anything that ENT specialty can help?
So you're saying in the presence of a huge goiter and surgery is not an option. We know that the thyroid is anterior to your trachea here. Okay. And so the compression from the thyroid, because you have the right and left lobes and the isthmus in the middle. For how the ENT would be able to help, or the head and neck surgeon, for cases of thyroid that is compressing on the trachea, we can still create an airway, although this is something that you would want to do with a bigger team and make sure you have anesthesia, because most cases you may have to divide the isthmus here so that you get to the trachea. So you should be able to have cautery and to stop bleeding when you divide, because the bigger the tumor, it's highly likely that you will have also an increased blood supply. So you divide the isthmus so that you can get to the trachea, and you can put your tracheostomy tube inside the trachea and relieve their obstruction. Which
Thank
was
you,
the
doctor.
second?
The second was from Senka, is asking on where you were talking about the tracheostomies, the cuffed, the fenestrated. I was wondering if those types are synthetic.
If there's any relevance to the tubes, why they are cuffed or fenestrated?
No.
Mm.
No, he was asking if the cuffs and the synthetic and the fenestrated, were they, I think, synthetic or metallic?
So
He's just asking about the types.
These are the metallic. So the metallic tubes are not cuffed. They don't have cuffs, okay? But they can have a fenestration. They may not be fenestrated. They can have cuffs. They may not be uncuffed. So for the metallic tubes, usually they don't have a cuff. You can't have a metallic cuff. They don't have a cuff, but they may be fenestrated or not. So for the case of someone who needs tracheostomy for a long time, the metallic one would be good, but they're not readily available. What is more available is these others, the synthetic ones compared to the metallic ones. And the metallic ones, maybe the other thing is that they can be reused by more than one person if they are sterilized, which is not the same for the synthetic. These ones are single use.
Okay, thank you, Dr. Ruth. There's one more question which I did not get. So I'll ask Alex Nahawe. Please unmute and ask your question clearly. Dr. Alex is off. Let me see if there are any other questions in the chat. His question was, I would need to know more light on how incisions are made.
Incisions are made. So
yes, that was
I'll go back. So I said the incision can be horizontal, and for the horizontal incision, your lateral limit is the sternocleidomastoid muscle. On the either side, you don't go beyond it. So this is your horizontal incision. The vertical will be like the name, it will be from here to here. So you make it either 2 to 3 centimeters vertically in the midline. Horizontal, you're considering the distance between here, midway the distance. You make your horizontal incision. It's preferable if you're going along the crease lines in the neck. So yeah, I don't know what additional thing they needed to know. So that is for the incision we are talking about is skin incision. When you go deeper, you sort of dissect along the midline. It doesn't matter if your skin incision was horizontal or vertical, you dissect along the midline.
Okay, thank you, doctor. The last question from Wonge says, are the layers still closed layer by layer? Or do we do thymus?
You're asking, are the layers crossed layer by layer?
Are they closed, yes, layer by layer, or something else?
Okay, so
And you told us because in 1 week it would have closed off. Then the second question was, what do we do to the thyroid after passing through the thymus?
okay, so the first question was asking about the layers. So when you're doing the thyroid, when you're doing the tracheostomy, you're going through the midline. If you realize that in the midline, the muscles are supposed to meet, so you're not going through the muscles directly. You're going to go through the fascia, which is sort of, or the easiest thing I can use is like the linea alba of the neck in the midline. The only thing that you cut through will be the thyroid. If you're not able to retract it superiorly, it will be the thyroid that you'll be cutting through. So and this is, you're creating just potential space. That means if there's no tube, these two muscles are going to get together. They will adhere to each other and the wound will close. You will not be able to go to the trachea directly. So that's why you make that incision, and you actually need to put sutures so that you keep it open. When those are removed, then these two layers on either side of your stomach can actually get together and close. Then you asked about what happens. What do you do with the isthmus when you make an incision? When you cut through it, of course, you're going to expect bleeding. So you need to ligate either side of it so that you stop the bleeding. But you don't always have to cut through it. For some, it is small and you just use retractors superiorly. Here it was cut, but you don't always have to cut it. When you cut, you have to ligate so that you stop the bleeding. You either ligate or you can cauterize to stop the bleeding. Any more questions?
Yes, there's one that's by who's saying air normally passes through the nose like normally. So what should we worry about, especially in permanent tracheostomy? I think for the part of the upper airway.
So air normally passes through the nose. So the nose does the humidification, warming of the air before it goes down. If you bypass this and you create a stoma here, you create a tracheostomy. That means the function of humidifying, cleaning of air, and warming is not going to happen. You're going to have air directly entering into the trachea. How do you help the patient? Some tracheostomy tubes have humidifiers and vents that can help to filter the air before it enters. Or for some cases, you can just improvise. They put a scarf around the neck so that sort of acts like something that would filter the air that they're taking in, so that they are not taking in dust and bacteria directly. So they can improvise with a scarf, a clean scarf over the tracheostomy tube. So their other concern is that also the function of the nose is to be able to smell. For someone with a tracheostomy will not have this function. They cannot smell. So maybe that is the other issue. And also when they're taking baths, bathing, that means they are, if they've not protected it well, water can be able to go in. So if they're taking baths, they have to be in an upright position. So that water is, it shouldn't be, maybe they're on a bed and you're pouring water on them. The chances are that it can actually get into the tracheostomy and they drown. So those are things that you need to look out for.
Okay, thank you so much, Dr. Ruth. There are no more questions, and you have exhaustively answered all of them. Thank you for the lecture.
Okay, so I am going to send this to the LMS so that you can be able to access it. And the details about the exams, we're going to get them from Dr. Jamila if you have any concern. If they're not anymore.
Doctor, thank you so much.
Okay.